This week we're going to cover chapter 8 of the book, which deals with late effects. We talked about late effects or chronic effects of different tissues in chapter 4. Late effects here refer more to the insidious effects that are often manifested after very, very long periods of time. The late effects here may not be observed for many years or may always remain dormant. We categorize these late effects into two different types. The first is somatic effects, where typically we might think of an exposed individual developing cancer much later in life, and genetic effects where the effects of irradiation aren't observed until future generations. Another factor to consider is whether the person is exposed in a sudden acute exposure, such as an atomic bomb or nuclear accident, or whether they were exposed to a very low dose over long times, such as occupational workers. So what are late effects? Previously, we looked at the effects of cells being killed by radiation. However, the late effects that we are considering now are due to those cells that survived the initial exposure, but in some way were affected. It is believed that carcinogenesis, the transformation of normal cells into cancer cells, is all or nothing. In other words, any dose, no matter how small, carries a probability that is also small of inducing a carcinogenic effect. No dose limit. Even small doses carry a risk. As the dose increases, the probability of developing cancer later in life also increases. However, the severity of the cancer is independent of the dose that the person was exposed to. In terms of somatic effects, we are talking about carcinogenesis. Radiation has long been known to be a carcinogen, a cancer-inducing agent, and with low-dose exposures, such as those received by occupational workers or patients undergoing diagnostic tests, cancer is the main concern. This dates back to the early 1900s. In 1902, a radiology technician had a carcinoma, a cancer that forms in epithelial tissue, on his hand. Within 15 years of X-rays being discovered, there had been 100 documented cases of skin cancer caused by the radiation. Marie Curie, a pioneer in nuclear science, died of leukemia from her work with radium, and when she died she was nearly blind from cataracts. Her daughter Irene discovered the first ever artificially created radioactive atoms, and died prematurely at age 58 of leukemia in the Curie Hospital in Paris. So what is the risk? Typically, we might want to know what the chances of developing cancer are and when it might occur. This is different for different cancers and different exposures. For example, an increased incidence in leukemia appears after irradiation, and this increased incidence appears to peak between 7 and 12 years and then drop at later times. For different types of solid tumours, there is an increased risk of incidence also after irradiation. The increased incidence, that is the number of cancer deaths above what might normally be expected in a population, continually increase with time. The mean latent time for the appearance of all radiation-induced cancers is often taken to be about 25 years. But as you can see from the straight line, it doesn't exactly peak. Recall that exposure to radiation causes stochastic changes to cells. The question is whether this exposure causes an absolute risk of developing cancer, which seems to be the case with leukemia, where the risk increases and then decreases later, or whether there's a relative risk that increases by a constant factor as a person ages, which seems to be the case for all solid cancers. When we talk about risk, what we are really considering is the excess chance of developing cancer through the lifetime of the person due to the exposure at some point. This depends on dose, and because of the stochastic nature of radiation, even a small dose carries a small risk. The effects of very low doses is important when considering nuclear medicine diagnostic tests, both for the patient and for occupational workers. The linear no-threshold model is the most common model for estimating the risk at low doses. In particular, we take the risk for higher doses, which are easier to measure, and we extrapolate to lower doses where the data is inconclusive and noisy. The dose is usually given in sieverts, which is an SI unit that takes into consideration the biological effect of different radiation types. In particular, the dose is multiplied by a quality factor that allows for the different biological effects of different types of radiation, similar to RBE. In older books, REMS might be used as the unit for dose, but sieverts is the unit that is commonly most used now. The data shows a very clear increased risk of cancer for doses greater than 10 to 50 millisieverts, at least for acute exposure. That is, when the dose is delivered in a short period of time. However, for protracted exposure over a long period of time, the evidence only exists for doses greater than 50 to 100 millisieverts. For acute exposure, there is an excess chance of developing cancer of around 1% for 100 millisieverts, or 10 REMS. Using the linear no-threshold model, we can find the excess chance of developing cancer for a given dose of radiation by simply setting up a ratio. For example, 200 millisieverts would correspond to 2%. There are other factors might increase or decrease this risk. For example, the bystander effect has been observed in many systems where DNA damage to an irradiated cell causes damage to neighboring cells that were never irradiated. Alternatively, there is an effect called hormesis, where it is believed that small doses of radiation can stimulate a biological response that is beneficial overall. We'll come back to this later. For now, following the International Commission on Radiological Protection, we will assume the no-threshold model. The linear no-threshold model assumes that the excess lifetime risk of developing a radiation-induced cancer after an acute exposure is 1 sieverts is 10%. However, if the exposure is prolonged, perhaps over weeks or months, then that risk is reduced to half. There would only be a 5% excess chance of developing cancer for the same 1 sieverts of radiation. Technically, grays are the dose, and sieverts represent the effect of the radiation dose on the body. For beta and gamma, 1 gray produces 1 sievert of effect, but because alpha particles are much more dangerous to the body, 1 gray of alpha particles would produce an effect of 20 sieverts. A lot of what we know concerning the risk of cancer come from epidemiological studies surrounding Hiroshima and Nagasaki. However, it is worth noting that the massive spike or pulse of radiation has a different effect than the same dose of radiation from a prolonged exposure, say from working in nuclear medicine or living in a contaminated area near Chernobyl. It has also been pointed out that Hiroshima and Nagasaki bomb survivors inhaled carcinogenic benzopyrene from the burning cities, and this is something that has not been accounted for. In terms of low dose estimates, therefore, while the studies indicate that there is a definite risk of developing cancer when exposed to low doses of radiation, it is very difficult to quantify the degree of this risk. The linear no threshold model is a simple to use tool for estimating cancer risks, and if anything, it's more likely to overestimate the risk than underestimate the risk. That said, the linear no threshold model at low doses is not based upon scientific data, but rather chosen for convenience. Alternative models do exist, and they can be fitted, at least to the high dose data, equally as well as the linear no threshold model. For example, a linear quadratic model might be potentially interesting because we have seen linear quadratic behavior in other radiobiological systems. However, there is no justification for any alternative models.